Good day, good afternoon, good morning, good evening, depending on where you are on this fast forward planet Earth, in which the human species is grappling with a novel virus that jumped the tracks, so to speak, in China back in November or so, and has now become a global calamity, both medical and economic. I'm Andy Revkin. I'm at the Earth Institute, where we have a new initiative on communication and sustainability. The focus is to make information matter. And that's what these conversations are about. This is the second one today on this question of whether we can fast track getting surveillance and advance word of COVID-19 risk by tracking the wastewater, the effluent from communities, while we're working out this mass testing and tracking and tracing and isolation protocol. That's not like that's the only thing to do. And there's a great group of researchers from Yale through to Arizona State and around the world who are working actively on this question. The paper that brought this new session to mind was out of Yale. It's a working paper. Again, there's a lot of this rapid turnaround research happening right now. And we just have Jordan Petia, one of the authors, who's going to join us in a second. Great panel today to discuss the next hour with our audience, for whom this is designed. We're going to discuss ways. What are the action points? What are the conversations that aren't happening? Who's not in the room? Rolf Halden, who's here from Arizona State's Biodesign Institute, laid out a month ago some of the really interesting questions about the practical questions. It's not just can you find the virus and waste, and can you know how much is there, and can you know what that relates to illness? It's how do we actually get this done when you have wastewater treatment plants with their own regulatory systems, when you have agencies that don't talk to each other very well. So, and I do see that Jordan is on the line. So Jordan, good to have you here.
And nice to be here. Thank you.
Can you hear me? Jordan Petia is an environmental engineer at Yale. And I'm going to switch the screen view in a minute, just so we can see you more directly. Again, we have Rolf Halden and Devin Bose, who are both from Arizona State University's innovative programs in water and health monitoring and action. Howard Frumkin, who is a former dean of environmental health, is that correct? At the University of Washington, who's emeritus now, and he ran the National Center for Environmental Health. That's for the CDC back in the day. And Angie Rasmussen, a virologist from Columbia University's public health and medical side. And we're really happy that this connectivity between the Earth Institute and you folks, because a big chunk of the Earth system is biological. And these connections, if we don't understand the connections between how viruses move and how we move and act, we're kind of stuck. But let's start with Jordan and this study. And obviously, this is not the first study or initiative you guys have been at there at Yale. So just if you could briefly describe where you're at on this question of COVID-19 and wastewater. I mean, the SARS-CoV-2 and wastewater.
I'd be happy to. So I've been working with a group of engineers and epidemiologists since mid-March, when we knew that an outbreak was on its way to New Haven, probably already there, but we didn't have testing data at that time. And we mobilized pretty quickly and started taking samples from New Haven's wastewater treatment facility. And the reason we decided to do that is because I have some background in testing for viruses in sewage sludge through land application problems. The idea that when the sludge is been removed from wastewater, the EPA mostly recommends that it be land applied as a soil conditioning product. There are viruses and pathogens in the sludge, and people can become exposed to it. And so we had 8-10 years history working in sludge. And so we decided that we would try and sample the sludge, because sewers are difficult for sure. In the New Haven wastewater treatment plant, the wastewater comes in. It is settled in a process called primary sedimentation. The solids from that sedimentation are then go into something called a gravity thickener, where you think of it maybe as a bunch of sludge in a colander with the water dripping out of it. And then it leaves. By that time, though, it has been concentrated and it has been mixed to some extent, and we take the sample at that point. And so what we've been doing is taking these samples, storing them in a -80 freezer until we figured out the best way to extract the RNA cleanly without inhibition, And we've been quantifying by, the standards reverse transcriptase PCR methods. And we did so from March 19th. And, I picked up our sample today. We're still going.
And this new study that just came out, the one that got my attention focused on your work, it seems to imply that you're validating this concept that there can be essentially a critical advanced hint of trouble. Is that a fair way to describe?
I think that's right. I think that's right. We had been hopeful that we would be able to see some sort of curve out of the data. And it became pretty apparent because we looked at this a couple different ways. We've done replicates and different types of primers that we do see the concentration of SARS-CoV-2 RNA in sewage go up and down with the outbreak in New Haven. Not only do we see it track the outbreak, we see it track hospital admissions in the area. And when we plot it all out, we see that the data seems to be shifted to the left, that is earlier in time. And if you match peak to peak, our data peaks about 7 days or a week earlier than the testing data we get. Now, we'd expect that to happen based on the fact that, if you are sick and infected, you're going to be contributing virus to a wastewater treatment plant regardless of your symptoms. And it takes a while to become symptomatic. And even after that, it takes a while to sometimes get tested. It may take a while from the testing to show up in a database somewhere. And so there is some lag. And so we think that we're probably just cutting out much of that lag by testing the wastewater.
So I'd like to bring Rolf in a little bit because the discussion we had in April, he's been at this a while. And again, there's this arena, a large number of groups around the world have been focused on this, including before this virus, for other virus outbreaks. Of course, in fact, there's monitoring for wastewater for polio in the past as well. So how does what you just heard mesh with some of the work you've been doing there at Arizona State?
Well, first of all, I'd like to congratulate Jordan on his amazing work. He has been playing with sewage sludge for a long time, as have we, so we are probably very familiar with each other's work. And, used to play in a playground that everyone else avoided because there's no money, there's no glory in sewage sludge, but it has, it's something that we produce as we treat water. But we have moved from the fringe to the focal point of attention. And so I think what I heard when Jordan spoke was that he very carefully delivered his conclusions from the work. A lot of people are looking for silver bullets. There's a lot of newcomers coming to the table, and they seem like, oh yeah, I'm going to be the first one to claim this magic weapon. It's going to take down the virus. It's not like that. There's anyone who has worked with wastewater just a few years knows that it offers tremendous opportunity as well as huge challenges. And I encourage everyone, if you have a new tool and you want to use it wisely, who do you ask? Go to the people who are the tool makers, the people who made the tool, tried it, had made all the mistakes in the past. Those are the people we should turn to right now to figure out what can and cannot be done. And there's actually just, a very few very few of us that have been doing this for years or even decades. But it's important we don't have time right now to waste making the same mistakes or overstating something that has some utility. And I think we've seen this with drugs. If we overpromise on something, then we are disappointed and at risk of abandoning something that in principle could be useful. So I caution that I'm optimistic that this tool is good. It is not perfect, and we have to be aware of its weaknesses. But I wouldn't be here if I wouldn't think that there is something that we can do for public health right now using this long neglected tool of wastewater-based epidemiology and what we call sewage sludge epidemiology, because there's lots of information in sewage sludge as well.
We're gonna get to Devin's One Water, One Health project and Howard's that view that you have from the epidemiological and policy community, and Angie from virology and how that laces with this in a second. But I wanted to note something really valuable that happened. A few weeks ago. It was right after we did our initial conversation. I think around the end of the month, the Water Research Foundation convened a symposium, and on these issues, and there were some really interesting intersectional dialogues there. And I think this just feels like one of the really important steps related to the urgency you talked about. What can you do, where there isn't a risk added in moving forward to expand some of this capacity to understand how this could work, given the fact that the other initiatives that would need to happen are also super slow-mo in some parts of the country to get into gear. Community testing, individual testing and tracing, as Howard Frumkin described here, we need a mass push there as well. So I guess I'd like, Howard, maybe can you weigh in, again, as an observer of the overall landscape, and you recently pushed for the big and large push. You really pushed, to expand the basic conventional testing and tracing in almost a wartime scale. And obviously that's the kind of thing will be needed. So how does this feel as a possible side parallel effort?
Well, thanks, Andy, and congratulations both to the Arizona group and the Yale group for really interesting work. I'm going to jump all the way from the science and technology to the end game, and I think that's where the question that you asked takes us, Andy. So let's imagine that we're sometime in the next year, and we're going through a waxing and waning pattern of the coronavirus pandemic. We're watching out for reemergence of disease once we've quieted things down a little bit, and we know that reemergence will come from time to time. And what we want to know is, as soon as we can, when is it going to happen? And the reason we want to know that is that policymakers, governors, mayors, heads of health departments will then tell the public something's coming. We're on an upswing. It's time to start wearing your masks again and begin that physical distancing again. We're going to ramp up our contact tracing again when people test positive. So it's time to get back into action. So the question is, in my mind, will a signal from wastewater be enough to empower officials to do those things? Now, remember that we're in a time of intense political pressure to reopen the country now. About a third of the states have rising patterns of COVID-19 infections, and they're still opening up anyway. Not because it makes public health sense, but because the balance of opening the economy and fighting the disease is decided by political factors. So I guess the question I want to ask both the Yale and the Arizona groups is the science good enough, and is the advance warning reliable enough that you think a governor would listen to this and take steps to begin to close down a state again? And if not, what would it take to get to that point?
Well, maybe, Ralph, can you start by talking about Tempe?
Yeah, so I think, Howard, that's a great question, because if the information is not actionable, then why do we collect it, right? So it has to be something that really makes a difference. And I think we have a case study in that, because we monitored for the city of Tempe in Arizona opioids for over 2 years, and met with decision makers of the city every month, all the stakeholders, and discussed what the types of drugs we found, as well as the concentrations, and agonized about where resources that are limited should be applied, in every given moment to combat the opioid epidemic. Unfortunately, we have now added another pandemic on top of that, and that's, of course, the COVID-19 pandemic. And so we pivoted quickly and put up the dashboard that you see right now that Andy is displaying. And so this is another real-time dashboard, another first in the world, that displays information on the public health status for all community members to see and to interpret. And I think what we already learned is that for politicians and public health officials, it is very difficult to communicate strategies absent of a foundation of reasons why those actions should be taken. And what we feel is that we will provide one facet of many, that will inform on the need and the prudence of either shutting down the country or keep going, because shutting down is just as harmful to public health as is the virus when it infects people. It costs lives, and it diminishes quality of life, and so there's huge kind of stakes that we have to balance, both economically and public health. Let's hear from Jordan.
Well, we're in touch with the city officials, the public health and the political officials in our city as well. We're giving them this data as we get it. And we're hopeful to them that it can be useful. Now, there are two ways, at least, to think about it. One is, so maybe you don't act on the wastewater data in itself, but now you have testing data and wastewater data. These are relatively independent measures. And so it can give some background and some heft to decisions that are being made, because now you have two things that you're looking at. I totally agree with you that the key question is, if you see the wastewater go up and you think it's a leading indicator, what do you do? I don't have an answer for that other than to say that in our case, I feel like the data is robust and that it's probably a real thing. When we see little humps in our data, we see that in testing, we see it independently in our SARS-CoV-2 testing of wastewater. So I feel like it's a robust, and I think it would be important to acknowledge that. I'm worried also about an issue that Rolf brought up, and that is that there are a lot of people who are going to do this, and there are a lot of reasons why you may not detect SARS in wastewater, and there are some reasons why you may detect it when it's not there.
Yeah.
And I worry about that information getting out.
False positives, false negatives.
Absolutely.
Yeah, let's bring in Devin. You're at the interface of public health and community response. But first, I want to talk to Angie about the virus. There was a question that came in. I'm going to just show it for a second because it might block your view. Chris Candiday says, this is very important, and a reading of the paper brings up the following questions and comments. Are they finding infective virus particles or only pieces of stray RNA, or can they tell? Is this RNA coming from feces, urine, people coughing into sinks, or all the above? What is the cost of each of these samples compared to the sampling? So cost, and I think I remember Rolf talking about how cheap this is, potentially. The authors, whoops, there was part to the question that I can't fit on the screen right now. So let's talk about the virus and these signals and this question. Angie, again, you're operating in that interface between data on the virus itself and the public. And what does this feel like to you?
Well, that question really kind of gets at something that has been a source of confusion, I think, around testing and risk of being infected with or exposed to this virus since really the beginning. And that is the confusion between detecting viral RNA and detecting actual infectious virus. So my understanding is that that you did look at RNA using qRT-PCR. And for testing, to determine, it depends really on what question you're asking, whether that's going to be sufficient. So if you are trying to determine how long somebody who's recovered from COVID-19 might be still infectious, in those cases, you do need to look for infectious virus. Similarly, if you want to know how long virus is persisting on a surface that could potentially infect you via fomite transmission, you want to look at actual infectious virus by doing a plaque assay or a 50% tissue culture infectious dose assay, something that will measure whether or not that virus can be infectious. In this case, however, I don't think that anybody has suggested that we're actually measuring the risk in wastewater. We're not looking for infectious virus in wastewater for this purpose. You're trying to understand, you're using this as a tool essentially to sample the community and see if the levels of virus in that community are actually changing. If they were to go up, say, and that would indicate increased transmission in the community, more cases, then you would presumably want to redirect resources to actually identify who those cases are to break these transmission chains. And that's why this would be one piece in a surveillance puzzle that would also include traditional epidemiological approaches, such as conventional testing for virus to find out individual people who are infected within that community, and then do contact tracing, this really classical time-tested epidemiological approach to actually break those chains of transmission. So in this case, it's not really, I don't think it's important. The standard should not be whether or not you can culture infectious virus out of wastewater, because in this case, we're just using it as an indicator of communities and the level at which virus might be present in those and being transmitted within them.
So one question I have is is there the prospect, let's take Tempe obviously you have a sewage system that's mapped, and can you sample it within the city and get a sort of like, about Flu Near You, which is a very different kind of a vehicle for community reported flu symptoms. But could you have sort of a heat map of a city where you're seeing, the virus signal in one neighborhood is going up, and have that something that is a publicly available sign to the community? As Howard was saying, the communication questions here are significant, but is that something that could work? And maybe Devin, I'd love to hear from you on that too, because you're sort of at that scale of one water, one health community impact.
Yeah, thank you. So to your immediate question, if you're able to go back to the dashboard, so we're actually able to see at neighborhood level, at least within the case study of the city of Tempe, the ebbs and flows throughout the city. I think if you just scroll down a tad more. So you'll eventually you'll see a map. So the colors are coordinated to what you see on the graph there. And we're able to see, throughout the entire city as a whole, but also within each neighborhood, what that progression or decline can look like. So between area 1 and between area 3, for example. To everyone else's point, so I represent One Water, One Health, and it's a nonprofit project of the Arizona State University Foundation. So our goal is to basically bring wastewater testing to those who might not be, under the case of COVID-19 right now, getting the testing that they need just so that they can make informed decisions within their community. So this is something that we do regularly with other biomarkers. So Rolf mentioned before drug use, but also other public health measures. My personal take is on dietary measurements. So all of this is just to understand in an orchestrated effort with traditional data sets as well, the health status of a community. So right now, obviously, COVID-19 is on the forefront of everyone's minds. So that's what One Water, One Health is focusing most of our efforts in right now. And we're offering screening in those types of communities who might not be getting the testing they need to be most well-informed. But beyond that, we are interested in other measures of public health.
That's fantastic. That Howard, when you look at that map, what does that say to you?
Well, I'm a non-expert, so it raises lots of questions in my mind. I love the idea of a heat map. Yeah. So I wonder about some of the factors that play into the results, and I would just like to ask the technical experts here. What happens if you have a rainy day followed by some dry days? Do you have different levels of flow in your system, changing the concentration? What happens if the temperature changes? Do you see different levels of viral recovery or viral fragment recovery, whatever it is we're recovering? Do those levels change with degradation with temperature? Other chemical components, lots of things that you must have thought hard about that would determine the extent to which you can recover a signal. That flat surface across the middle of the graph there seems to say that many, many samples were at the level of detection. But it would be great to understand that. What are the factors that determine when you can see a signal and when you don't, and what might make you right or wrong? Help us understand the graph.
Let's hear it.
Okay, yeah, so so we find the data overall encouraging. What you see is when we started, we had detectable levels, particularly in this large blue area, which is about 100,000 people in Tempe. We had concentrations that were in the range of almost 1 million counts, so virus particle or genes per liter of wastewater. And then we entered the lockdown period, and during the lockdown, which is then going through the March to the month of April and into May, we see that the levels go below the detection limit, and that's the magical line here of less than 5,000. So we display the data as if they reach 5,000. We really don't know whether it's 4,900 or whether it's 200. But what's clear here is that we have a signal that sees a lot of modulation, so it has a large dynamic range. And so you see one area there where the count was in the millions, and then drops down to below the detection limit during the lockdown. And another observation, so this is only one of over 100 cities and neighborhoods that we are measuring. And we have a neighboring community here where during the same time where all the Tempe areas, which were really in lockdown, showed these low detections. And we have another community here that was more active and socially engaged, and they still have counts in the high hundreds of thousands per liter, which reinforces that there is value in this signal. But to go back to Howard's question about what exactly does a signal mean and how can it be changed, these are questions that we are still trying to understand. And oversimplifications are not really helpful right now. I think you're best off if you count what's a reality. So the gene count per liter, that's real, right? That's the physical measurement, like a temperature. But whether the temperature is caused by a Bunsen burner next to your thermometer or by the sun being millions of light years away, that you can't tell. And so I think let's just live with what we know right now, is that if we measure the virus, we know there's a risk factor in the population. If the virus count is particularly high and particularly correlated with high numbers of hospitalization, then we don't want this value to go up again. And it's also good, given the sacrifice that people make when they go into lockdown and into unwanted unemployment and so forth. It's good to see that there is a signal that we can track that tells us that this is a worthwhile endeavor. But in this particular city here has a separate sewer system, so we don't combine the rain flow with the municipal sewage. But that happens in some communities, particularly in all the cities on the East Coast. So these are all the right questions to ask. And if you forget about them and just look at, data always look good when they're black and white on paper. But if you ask a little bit look behind the curtain, you find, that there's very difficult decisions to make in the interpretation and so forth. And we try to give you here kind of the temperature reading. This is the temperature that we have right now in Tempe by neighborhood. We know that some areas are a little hotter than others. They all have come down, so it looks like the intervention has worked. But we also know that it has, caused a lot of pain. And so we have, as Devin mentioned, we also have a program in place where we measure biomarkers of general health going beyond just the virus presence. And so we are tracking those two to understand what the public health situation is, whether it's dietary status, stress hormones, consumption of alcohol, nicotine, caffeine, and drugs, all things that are happening as we change our behavior because we are forced to stay indoors and can't pursue our regular lifestyle.
So I wish my wife was on the call because she's an elected official in my village in the Hudson River Valley, and they have a weekly call to weighing this balance of public health and businesses trying to reopen, and where's our testing, and the uncertainty levels are deep. And the key, she said in this, at every scale of this problem, we're driving a car while we're building the car. And that means even in terms of village policy. So I guess that leads me back to that first session I did with Rolf, and also to the Watershed Research Group. I mean, the Water Research Foundation. Are we as deeply underinvested in answering the basic questions here, just in like driving the science? As it appears to me that we are, compared to what we spend. Does NIH even have a component that gets into this level of the issue of pandemic preparedness?
We are certainly deeply underinvested when it comes to, understanding epidemics through wastewater. Absolutely. And that's partly just because, that's traditionally not been a common thing to do, at least in the United States. And right now, it seems like it's becoming an important thing to do and has some real practical applications. Hopefully that'll change, but certainly at this point, there's a lot that we don't know.
Because, and Angie, you see the overall landscape pretty well from where you are too. Is this like a corner of the conversation that's vaguely in the mix, or is this really a big part of the conversation?
I mean, I think it's something that I've been hearing about increasingly. People are understanding that as our testing capacity for testing people has still not risen to the levels that it needs to be at, really to actively monitor cases across the country in a huge population like the United States, there need to be other pieces of the puzzle. And I think people do understand that wastewater is an inexpensive and effective way to conduct community level surveillance. So I think that, it's getting more and more traction. I think that it especially in places in states where they really haven't ramped up the testing and contact tracing capabilities, that this might be a cheap and pretty effective way to monitor broader communities. I mean, it's one tool among multiple tools to potentially do this, but I think that people have certainly been talking about it more and more, especially as some states are moving much more aggressively to reopen.
I'm going to show the screen, the One Water, One Health project. And hold on. Devin, could you describe the broader landscape of what you guys are working to try to develop here? Because it relates to some other initiatives that I've been tracking.
Absolutely. So when we started out, we knew that wastewater was obviously a great, we might be a little biased, but it was a great resource of information. But essentially, we are interested in environmental health as well as human health, and there are obvious relations there. So we want to learn about exposure in communities. We want to learn about nutrients that we can essentially recover, so resource recovery, and learn about kind of the environmental footprint, if you will, of our dietary choices that we make. So these are all things that we can learn through wastewater and through essentially long-term monitoring in communities, understanding trends and getting a feel for what the typical behavior is, as well as what might be ending up in the wastewater streams that could be harmful to both the environment and the community that is living in that environment. So building materials is something that we are considering taking a look at, and just general runoff from industrial places of business as well. So that's a very broad overview. But so for a short period of time, we were struggling with trying to figure out what was our best foot forward. And then COVID came along, and we decided that that would be our best, absolutely, case study that we can start off with. And it really, truly, with all of the news that has been coming up as far as this virus shedding light on health disparities, we really feel like that we have a place and that we can make a difference in those communities.
So much of this has to do with mapping and data. And at the National Geographic Society, when I was there a couple of years ago, they were building a global map essentially to help foster better conservation outcomes in developing countries through access to data. And this is basically a very similar concept. At the Atlantic Council, I noticed David Bray recently, early April, he put out a proposal for, they have a geotech initiative there on using data more creatively for sustainability and resilience. And the concept of an immune system for the planet, essentially taking the scale of Tempe or New Haven and thinking, what do we do better so that when there's early signs of trouble in Wuhan or wherever, we are all getting that data, the right communities at the right time. This even relates to a session I did last week on the cyclone heading toward Bangladesh, where we were trying to build interfaces between Earth Institute scientists and Bangladeshi forecasters and communities. And, we all think about the downside of all this connectedness. The infodemic is in the foreground these days, thanks to a president who can't stop tweeting and so many other aspects of how social media are designed. But this all feels to me encouraging. If this becomes, whether it's this particular example of wastewater monitoring for surveillance or some of these broader scale questions, I think maybe could we be driven toward finally getting real on these things? Ralph, you also had this, you talked about a human health observatory aspect to what you're doing too. Do you feel excited or frustrated by where we're at? The gap between action and data and information is huge.
Well, I think that the US is really lagging behind in terms of the research on the federal level and the organization around this topic. It's not that we don't have good scientists, but we haven't kind of fostered that type of science, which now pays huge potential, public benefits. And if you look across, the Atlantic, there's many nations, and then also around the world. So Australia has a nationwide illicit drug monitoring network, right? In Europe, over 60 cities have annual surveys on drug use. The Netherlands, I think Sweden and others have now stood up just for COVID-19 nationwide initiatives. And America is still asking questions like, is there meaningful information in wastewater? But of course there is, and there always has been, and there's hundreds of papers. I mean, our group alone has published over 100 papers on things that we can measure that are useful to understand public health. See, one thing about the United States is coming from Europe is that we love medicine, boy, and we foster it. It's like our favorite child, and we throw money at it like there's no tomorrow. But public health isn't all that popular. It's people, it's not individuals. We can identify with individuals, with people, and with populations. But public health is what keeps people healthy, so they don't get sick and they don't need to see a doctor. So the investments made in public health protection, they pay off by the millions for every dollar you put in. And we're not doing this in America. It's a systematic mistake that we make over and over, and we are failing to learn that lesson. And I think if we don't get on this bandwagon quickly of standing up a nationwide network, then we really fail our populations, and we drive people into sickness and potential death if we fail to make those decisions. And so we just started strategically over 12 years ago to begin what we call the Human Health Observatory, where we acquired samples of wastewater and sewage sludges, not just from the United States, but from around the world. We have over 450 locations now around the world. Over 250 million people are represented in the chemistry that is stored in our freezers. We can go back in time and see whether a virus was there and when it emerged and what the concentration was. We see carcinogens that are pumped into the environment. We see air pollutants that are there. But not only that, we also measure the exposure. So the metabolites that the body forms when we inhale, when we get exposed to pollutants, our body creates in response specific metabolites, chemicals that tell us that this chemical has been in the human body and has caused a human exposure. We measure those too, and guess what? There's a direct correlation between how much we pollute the environment and how much polluted we are. And so we measure all this, and it's no secret. But if we would learn that lesson and convert it into action, we would not have the additional cancer cases, right? And so that is just something that is missing. And so I look forward to a quick, concerted effort where the United States catches up with the global community and stands up a nationwide network. And there are already, beginning clusters. There's a few groups that have, monitor more than 50 wastewater treatment plants. Ours is probably the largest because we've been doing this for the longest time. We have over 300 locations across the United States. We measure in over 100 neighborhoods for COVID in the US right now. I heard today in the National Academy of Sciences webcast that Stanford is doing in the laboratory environment at the research level, about just short of 50 wastewater treatment plants. We have on the East Coast in Massachusetts, we have a lab that analyzes dozens of wastewater treatment plants. So we need to bind together those people that can do this and stand it up quickly, and then learn the hard lessons. Not everything will work out, and we have to harmonize some of the methods. It won't be all the same, but we have to have some common standards by which we judge the data, and then communicate it and ask the questions. Where is this data being used? How is it useful? How do you communicate it? That's important. Just having scientific papers will not help anyone. How is it going to be communicated? And we have learned those lessons by developing the dashboard for opioids and for COVID-19 with the city of Tempe. Different audiences require a different format in which you present the information, how you communicate it, and so forth. And these are all hard lessons. We don't have a lot of time to waste, so let's not make the same mistakes again.
Yeah, so maybe I'd like to have each of you weigh in on some particular step or some particular person who would need to be in the conversation to get this moving forward with more support. It's so challenging in the United States. It's called the United States, but when you look at health issues, it's always a struggle, as Howard would know very well from his experience at CDC, to deal with the states versus federal initiatives, and also the private sector in a health system that's mostly private still, with the all the issues we have about insurance. And is there another finance model for this? Like, should whose interest is it in to have better public health? It's kind of a public good, but in the United States, we're not really good at capturing that. So Howard, if you could kind of weigh into that, and then we could circle through to Yale and the rest before we end.
Yeah, well, it's a great question, and it really is in some ways the biggest meta question underlying our conversation today. We don't have a health system; we have a health non-system, and so to lay in public health on top of the emphasis on clinical medicine faces the double challenge of the obsession with medical care as opposed to prevention, and with the absence of an organized system. It's never been more clear than under the COVID-19 pandemic. So I think the good thing is that coming out of this deep economic depression offers us a lot of opportunity to think big, to think on the scale of coming out of the Great Depression in the last century. And nationwide system building, like the kind that Ralph was just suggesting, is maybe a greater possibility now than it's ever been in our lifetimes. I wonder if I could pose a question since I have the podium for a second.
Totally.
We talked about sampling wastewater systems, but Andy, your slide on an immune system for the globe was very intriguing. It raises the question, in my mind, of whether we might do wastewater sampling in specific potential hotspots, like concentrated animal feed operations, where we think there is an opportunity for viruses to migrate or mutate, and where bad actors may emerge. Is that a form of an early warning system we could be thinking about? Not so much in conventional sewage systems, municipal sewage systems, but in the outflows from hotspots.
Ralph, we talked about that a month ago, and when I brought up informal settlements, human settlements, it obviously, when I was in Kibera, the slums in Nairobi, you can see absolutely which streams are the aggregator. I assume the same is true at a slaughterhouse or anywhere else.
That's right. So I think any place where you see the composited health information of either animals or people, coalesce into an information stream, that's great to tap in. And so we call the sewers, the information superhighway where barely anyone plugs in, because there's so much information in there. Yes, it's not attractive, but it sure delivers. And the doctor draws on the same resources, urine, stool, to give you, your personal health information. So why wouldn't we do it for a city?
Wow.
But there's an aspect of equity. And I think, Howard, you're driving to that the clinical assays will never reach the underdeveloped, still developing parts of our planet, and populations will not see those benefits. And I think that's where we can really make a difference in rural America, in places where of low social economic status, in developing countries around the world. We do measurements for Central and South America now. We know that Ecuador has been hit very hard. There's a lot of places that will not see, this clinical testing of individuals. They are left alone there to either survive or die. And I think we can help them, inform them that there are threats and that they have to, step up their vigilance in order to protect themselves. And we have calculated, a paper we published 2 weeks ago, that we can reach 2.1 billion people. It's a quarter of the world population, just by looking to centralized wastewater treatment systems. If you add latrines, and if you add the rivers that drain through major cities that don't have wastewater treatment systems, there's a lot of information. And we're just beginning to scratch, on this information flow and begin to use it for the benefit of public health.
And at Yale, I've seen you have a Center for Global Health, and many colleagues in many different departments who are working as the same thing at Columbia. We've got Manav Lal has the Columbia Water Center. It feels to me like we all need to be talking to each other more even within the campuses and across campuses. But what's the latest on that grander scale at Yale, Jordan?
Well, I think what I worry about is that that's just been brought up, is that there is not a great finance model to continue this work. Right now, we finance this stuff through research.
Right.
And, maybe some of the research questions, while they're big and diffuse, are not completely what we need to be answering right now. We're going to answer those things through doing the work, but right now we're in the middle of an epidemic, and we need to be monitoring rural America.
You're speaking like an engineer. So many of the engineers I've gotten to know over the decades.
Very unusual engineer.
No, but like
research, and I appreciate it. But I think that when you look for resources to continue to do that, there are resources there if you want to do it as a research project. But if you want to help cities, right, they are not there.
Yeah.
So, and I think in particular, Rolf brought it up, and what our focus is turning to, hopefully, is rural America. And the epidemic there is slower to hit, could be longer, and of course, we know all the reasons why it could be more dangerous.
For sure. Angie, when you think about that interlinkage that's needed here and or a wider landscape of investment, what comes to mind?
I mean, I couldn't agree more that it's true. I mean, we don't even really have enough money for research for a lot of things, which has really left us very unprepared to deal with this pandemic. And I suspect without major policy changes with the pandemics to come in the future, I think that does require an investment both from the government, from individual communities, to implement some of these broader, more multidisciplinary practices to bring to the table for preparedness. And, it's excellent that you're now focusing the solution on rural America, which does appear as if it's about to ramp up into this patchwork or checkerboard epidemic that a lot of people have been predicting. If we had more crosstalk between virologists, public health officials, epidemiologists, people who have the capacity to test wastewater and monitor public health through a variety of different testing mechanisms, I think that's the kind of approach we need to be taking going forward. Personally, I just hope that there is an increased desire and public will to invest in this type of work. I'm not confident that there is right now, because the entire discussion with the public and as well as with policymakers is so confused and often kind of goes around in circles without people talking about real practical solutions. So we certainly need more research. We also need to invest in preparedness, which is really more of a logistical question. And really, as you said, transcends disciplines. And Andy, I mean, if it weren't for me communicating on Twitter about virology, I wouldn't have probably even met you.
I know.
And we're at the same institution. And two parts of that institution that, as you pointed out earlier, have a lot of relevance to one another and would really benefit from the other's expertise between the Earth Institute and the School of Public Health. So I think we really do need to focus on this and focus beyond strictly just research questions in terms of overall preparedness. I think it's a really complex question, and I just hope that we approach it in the right way going forward.
And I just got invited to join the author list for the next big 2022 global assessment report from the UN Disaster Risk Reduction Agency. And all the same discussions, the balance of the overinvestment on reaction and response compared to proactive and preparedness. This is not unique to sludge or to pandemic risk. It's the same institutional path-dependent failure to invest ahead for reduced impacts. And I do think a big chunk of this is a communication challenge, but it's, unfortunately, I see the impediments as pretty tough. And I saw Howard raised a finger, and I'd love to get him on here. Also, there are a couple of questions that came in. I want to get to those in the next couple of minutes too. Howard, what was your thinking?
Yeah, just to mention that in this context, I've been reflecting on some analyses that Bill Gates and others have done. If you compare the public health arena with the national defense and national security arena, the differences are striking, aren't they? We maintain a huge armed forces with many more people in uniform than we actually need to fight a war at any given time. We fund many, many streams of intelligence so the military can be prepared. And it's considered normal practice for the military to engage in scenario planning. Why aren't we doing that in public health? And it may be that this pandemic is the wake-up call to do that. A much larger public health workforce, not only in action, but reserves who can be called up when needed. Many more streams of information and intelligence coming in, and that I think would include the wastewater sampling that we're talking about, but much beyond that. And routine scenario building so that we can anticipate these things when they arise. the military is actually a quite well-funded and completely built-out example of how to do this that we can bring over to the public health realm.
So I'd like to get a little more input from you guys, but I do want to bring in a couple of questions that came up here. And also to mention that I've had 2 of the early sessions on this webcast were with national intelligence folks, Mark Mickleby, who wrote this incredible paper for the Joint Chiefs of Staff in 2009. So even within the military, saying we need a new definition of national security that works from the inside out, that bolsters basic public health, for example. This is 2009. So that it's not all about fighting the next war out there somewhere. And they are facing, I will say, the same challenges, the same inertia, the same. Alice Hill was on here saying the same thing, that scenarios are great, but you got to run the scenario, because otherwise you'll never know where the rusty ventilators are, et cetera. Right. So it's like, how do you do this stuff? So let me bring up these questions. Antonio Regalado, who's a fantastic journalist, he's covering the genetics CRISPR like no one I know. He's the best at that around the world. I joined for Technology Review. I joined late, but wondered if it's possible to do phylogenetics via wastewater to track new introductions, contributions of different versions of the virus. Just maybe a quick answer, Jacob, or
yeah, maybe I can answer that, because we have a funded proposal by the National Institute of Health to do so. And so we are using metagenomic sequencing and learning a lot about the different viruses. And this is an unfocused, so essentially we look at everything rather than make an assumption of what's there and just to try to tease that signal out.
I assume, Jacob,
I'd like to
hold on one second. And just because we're short of time, Jacob, I assume at Yale you're assessing various things like that.
Yeah, Jordan. We are.
Sorry.
That's okay. I was wondering who Jacob. Yeah. So we are doing that, and I would say metagenomics is a great way to do that, because you can get some strain dependent information. But there are approaches now that have been developed clinically where you can actually just pull the genome of just that virus out, and you can look at the diversity, and you can get some great information about transmission rates based on how that changes and evolves from transmission to transmission. So I think that's the next important frontier.
And Angie, I know you're working hard on that, tracking the evolution. We always think of these things in stationary ways. Here's the virus, but this is a dynamic evolving system, right?
Yeah, I mean, RNA viruses, and even though coronaviruses do mutate more slowly than other RNA viruses, they do mutate and they acquire new characteristics. And it's really important to understand that for a variety of reasons. It really tells you a lot about where the virus is coming from. You can use that to essentially understand how the virus is being introduced into communities by identifying different virus strains that are there. There's no evidence that for this virus, there are functional implications to these mutations, but in some cases that can indicate that the virus is under some sort of positive selection to acquire different traits. Again, I should add, there is absolutely no evidence that this virus and its mutations are linked to any sort of functional differences. But it is an important question to ask and to track, especially if you start seeing communities that are being affected in different ways. So there's really a lot of information we can get from phylogenetic analyses like that over the course of an epidemic, sometimes for some viruses, even within a single patient over the course of their infection. So it will be really critical to have as much information as we can about the strains that are circulating out there for, again, a variety of reasons.
And let me just show you one more question that came in. Deborah Thompson, who's a veterinarian, which I'm glad to see, because I wrote a piece like over 10 years ago during the H1N1 about the lack of crosstalk between the veterinary surveillance world and the medical surveillance world. But she's basically getting back to the policy landscape. Can you summarize how this country can centralize the wastewater treatment center concept? Or is that, I guess I would ask Rolf whether that's even necessary. It feels almost to me like a dream to think about that. So, but what would be the next best thing? Do you see ways of doing this through the executive branch, legislative? So what's your, what's the vision here?
Well, I think it has to happen. If you look back what happened with the United States, we were surprised by a crisis. We went to the breaker box and we pulled the main breaker for the country. We put the whole country into dormancy and we paid $1 trillion per month. And that hurts so much, so many people. That is personal now. Every decision being made is personal. We have to understand that we have a very large country that offers a lot of resilience. And so if we were to measure at specific plans and implement those data for decision making there, we should be able to keep our economy rolling and have rolling lockdowns, across the nation in different places where they are needed. And so if that message comes through, then the centralized and the nationwide survey will begin, and they will not let go, because once you have that data source, it becomes addictive. It is a data stream that you will not want to work without. And so I'm confident it will happen, but you have to realize it combines so many disciplines and different languages that it's really difficult to rally people around it. They hear different things, they have different expectations. So it is a learning exercise. And I wish they had an engineer who actually has experience with some of these fields, so that they can work as a translator in between to tell people what can and cannot be done and how to do it quickly.
Well, I think that's what your initiative, if I get it right, is trying to do. Certainly at Columbia, in general disaster risk, we have people at the Earth Institute, Andrew Kuchevitz, that's his job in the context of climate risk, is to work with communities in Bangladesh and elsewhere in the Bay of Bengal. And it's a profession. It's a condition. It's a gap in the system, I think, that really needs to be professionalized pretty much. It's not quite what I do. I'm just trying to foster better conversations. So I think that's a frontier as well. We're kind of toward the end here. I'd like to have each of you give a last thought in the context of your own work and what you do next. With that 5% solution in mind. This is Peter Coleman here at Columbia, who runs a Center on Difficult Conversations, among other things. He and others talk about, the incremental that gets you in the right direction. And I'm just going to use your ASU initiative as an example of iterative, adaptive capacities that can then spread. You started with opioids, right? Mm-hmm. In Ohio, there's a failing newspaper facing a community at risk from opioids 4 or so years ago. They created a new journalism model called Your Ohio Voice, where it's very engaged, interactive journalism, not just us telling you the story. And now they're trying to apply that in these new contexts, just as you started with opioids. And I think that getting started, having those little iterative experiments and then commuting, sharing them, like what's happening in New Haven, I think is another example, obviously. And what Columbia is doing by integrating its data with decision-making feels like a great way to get going. So any last thoughts? Devin, what's on your to-do list for later this week or this month?
Well, later this week is just collecting samples and processing and analyzing them. But in terms of just overall thoughts, coming from a nutritionist perspective, which is what my background is in, and looping back to our conversation between, shifting from a reactive to a proactive kind of society. I mean, we have 1.9 million new cases of, say, type 2 diabetes in the United States each year, and that is a largely preventable disease. So if we can use wastewater to track these types of trends and understand, from an early perspective, in what hotspots of an area are we seeing these biomarkers maybe on the rise, we can start to mitigate the true burden that people are experiencing, not just as healthcare and society as a whole. We can alleviate our doctors, we can alleviate those who are affected, and just overall create a more healthier, well-informed society. So those are my sort of lasting thoughts and impressions.
Great. So Angie, what's next for you? What are you doing when we get off this call?
I have another call with collaborators. Actually, first thing I'm plugging in my computer because it's about to die because I've been on calls and having interviews all morning. But what Devin just said really kind of resonates with me. I think that, one thing that testing capacity has been so important for, and why it's so necessary for this particular virus, is that testing is sometimes the only way that you can identify people who are infected early on, because we do know now that there is a substantial amount of pre-symptomatic transmission that occurs. So if you can't identify people based on their clinical symptoms, based on the fact that they recognize that they are actually sick, We need to have other methods that can detect these people as soon as possible so that they can be isolated, their contacts can be quarantined, and we can break these chains of community transmission. Any method that allows us to have another way to assess whether there are going to be more pre-symptomatic individuals who might be capable of transmitting the virus is going to be really critical to essentially reopening in a safe way in which we can really minimize this community transmission. So I'm glad that, you know, we have more than one tool that's available to us to do this, because the tool that everybody has been focusing on for so long, we still just don't have enough of them for every community. And I'm very skeptical that we're going to be at the type of testing capacity and throughput that we need to really do this at a national scale. So it's wonderful to have these alternatives that can contribute to really the big picture and allow us to intervene as soon as possible, both reducing transmission and potentially enabling better outcomes for those who still are infected.
That's such a vital. I'm glad we're having this conversation, and I'm hoping maybe ASU and Columbia can talk more about these things too. Last word from Jordan at Yale, and Howie. Maybe a going away thought from you, but Jordan, what's your priority?
We're doing this in the city of New Haven, but we want to do this for our entire state, rural areas as well as cities. You know, I hope New York City is going to do this too. I hope somebody from Governor Lamont's office or Governor Cuomo's office is hearing this and knows about this. And
send them the link when we're done. This is on LinkedIn, YouTube, Facebook, and Twitter. So
okay, good.
And Howie, you know, with that overview you have, and then knowing how things do or don't happen through government, what's your going away thought here?
Well, I guess two thoughts, Andy. One, this conversation has been great. It's great to learn about this technique, and it underlines the importance of data to support good and early prompt decision making. So I think in answer to Dr. Thompson's question, as the science is validated and as we understand better exactly what wastewater can tell us with regard to COVID and similar viruses, we need to create a national data stream. That needs to be part of the vision. I think CDC is probably the best way to do that. That's the agency that's within the executive branch that's empowered to aggregate national data relevant to health and to put that data out. Second piece is the communication piece, putting the data products out in ways that are believable to a skeptical public and useful to decision makers so that it can be the basis of good decisions in protecting public health, especially for the most vulnerable communities who need the protection more than anybody.
That's a great way to wrap things up. I'd like to just end by reading a little bit of boilerplate about this conversation. This is about number 45. I'm not sure. We've had 100,000 people have watched these just on Periscope. That doesn't even include the other platforms. So hopefully this is resonating in other places. And please, if when you're done watching, share. Oh, and Deborah actually asked a follow-up question, CDC or National Academies. I think CDC would be your answer.
Yes.
Sustain What is a global online conversation identifying solutions to the complicated, shape-shifting, and epic challenges of humanity's great acceleration, and now its great pause. A prime focus is making sense of and getting the most out of the planet's fast-forward information environment, the one Earth system changing faster than the actual environment. This webcast is produced as part of my work building Columbia University's Earth Institute initiative on communication and sustainability. If we had a hashtag, it would be Make Reality Cool Again. For the time being, these sessions focus on mitigating the unfolding catastrophe that's been brought upon by this virus, but also by the systemic issues underlying it. We'll dip into lots of other subjects and solutions as the time is right. Please share this when it's done, and send me your suggestions for future programs as well. Thank you all, and we could try to replicate this in a couple of months and see how we're doing. Keep pushing forward.
Great.
Thanks for being part of this.
Thanks, Andy.
Thanks, everybody.
Andy.